that which choice should be made?
My name is Ganapathy. I'm from London, Ontario, Canada. And the topic of this lecture was given to me via internet, which was a little bit different, and I didn't realize it had been changed. So I've tried giving only one slide pertaining to the topic that's declared on the main brochure. The topic that came to me was sciatic blocks. Do they modify pain management for foot and ankle surgeries? Is what I have from my internet. So that's what I'm going to talk on, but I'll show you one evidence to say ultrasound is better than peripheral nerve stimulation. What sciatic blocks do you do for the foot and ankle surgery? Once upon a time I did proximal sciatic blocks, and I just didn't like them because if you combine it with the femoral, their legs were like wet noodles, they couldn't get up and walk. So I went on to popliteal sciatic catheters and I was happy. Of late I might do the subgluteal or the mid-femoral blocks for the ankle and foot surgeries. Sometimes you can do a selective tibial or common peroneal. For example, if a patient comes for removal of lateral malleolar fixation, I'll just do a selective lateral common peroneal block somewhere behind the eye, behind the knee. And I do not want too high a block because of the hamstring weakness. Most of the time, if there is surgery in the femoral area, such as the medial malleolus, you've got to combine it with saphenous to cover that area of the medial malleolus. So isolated sciatic blocks sometimes are not adequate. So those are the areas where I can do the blocks. The subgluteal sciatic, which I'm talking about here, you can do the mid-thigh level, or you can do at the popliteal level. And you can get the components that supply the ankle and foot. And proximal sciatic, this is a cross-section, anatomic cross-section. So you can see the head of the femur, and you'll be coming from the posterior side, and that is the posterior side, gluteus maximus, that's where my sciatic nerve is. Okay, and that's the position for the subgluteal block. And thanks to Dr. Chan and Anna Hiperlas for sparing this slide for me. I don't have one of these slides in my bank, where the probe will be put, and that shows in plane or out of plane needle insertion. And in the popliteal area, we all know the anatomy. We've had extensive lectures and demonstrations on the popliteal sciatic block. So that is the common sciatic nerve right on the top, and it divides pretty soon at variable distance from the knee joint into peroneal and the tibial, and you could block it at the common level or at the selective level. And if it is lower down, you may do a selective tibial block in the mid-calf level too. That has been described. Sometimes in the diabetic patients, they may do the posterior tibial, what is called the ankle block, if they are doing foot ulcers, debridement, skin grafting, removal of callus, and all those things will be done with the posterior tibial block. And the saphenous block is done where this is the patella, femur, and that is the posterior side. And this must be medial because it shows gracilis and sartorius. That is a biceps femoris. Right in the middle is your sciatic block. And that can be blocked at different levels. By and large, it is done at the level of the patella. Okay, so this is the ultrasonographic picture. Low down, you will see it as two nerves, tibial and the peroneal being lateral. High up, it will look as a single nerve, which is a common sciatic nerve. Where is the evidence with regards to their efficacy? The best paper I have had with regards to how good this is for the patient was from Brian Ilfeld. He published it long ago, almost 10 years ago. At that time he was in Gainesville, Florida, along with Kaiser and Ecking. And that was his first major academic blast. He had so many of these nerve blocks evaluated for efficacy. And what he did, he compared it, which I didn't have the guts to do, to placebo. He put in the catheters and ran saline, or he ran ropivacaine. And what he noted was the worst pain, average pain, was completely way below what with the ropivacaine compared to placebo. By about the third day, they become similar because the ropivacaine blocks have been stopped. The worst pain also was significantly different between the two groups. And then they kind of even out. In fact, the ropivacaine group has a higher pain because it's that all or none. The block has worn off and they are in agony. And that's what taught me something. And we aggressively pursued multimodal analgesia in our institution. We started pre-operatively. Before the patient goes home, we give them something. We call them M&Ms. So because we give 7 pills before surgery, and the patients are wondering, are you giving me all this to swallow on an empty stomach? So we had to tell them this is just M&Ms, and they took it. And opioid in requirement was significantly eliminated on the first day by the popliteal sciatic block. But the requirements were very minimal for the next 48 hours. Boom, they go up. That is the effect of the block wearing off after the block is stopped. And what about the side effects? Nausea was eliminated completely. Sedation was significantly different between the groups. They all equalize on the third postoperative day when the block comes out. And pruritus was also eliminated. Insomnia was also significantly reduced. So obviously these blocks worked well. So there was a study about which way we should put the popliteal sciatic block. So they are looking at, should we use ultrasound guidance or should we use peripheral nerve stimulation? So this group randomized 51 patients to peripheral nerve stimulation or ultrasound for catheters. They injected 30 ml of 0.5% bupivacaine with epinephrine and spinal, and post-operatively they ran 0.2% ropivacaine 4 cc's per hour, bumped up for poor pain control scores up to 12 cc's per hour. They gave them IV PCA plus oral Percocets and hydromorphone. Ultrasound group used significantly lower ropivacaine. So that means the catheters were more precise. Or maybe they were under the facial sheath or under the outer epineurium. Whatever might have been the case, those blocks worked much better. But pain scores were similar. So if you want to reduce the opioid use, then you go for ultrasound. Postoperative analgesia after foot surgery, this was evaluated by Pia Di Benedetto from Italy. She compared the subgluteal, that's how she shows the picture. Greater trochanter, ischial tuberosity right from the middle, drop an 8 centimeter line, and you go perpendicularly in the intermuscular groove, and you get the sciatic block. And she had 60 patients randomized to subgluteal sciatic or popliteal sciatic, and she gave 20 cc of 0.75% ropivacaine, infusion at a nominal dose. Pain scores were similar. There were 2 catheter dislodgements per group. So there is basically no specific advantage of subgluteal over popliteal sciatic. I don't want any hamstring weakness. There are some hamstring supplies that come off somewhere around the subgluteal area. So I'm not excited about the subgluteal block for the foot and ankle surgery. And then she looked at the VAS scores. They are pretty similar between the two groups. There is not much of a difference between popliteal and subgluteal. In fact, the subgluteal had a little bit higher pain scores than the popliteal, but it doesn't reach statistical significance. And then she asked the patients to grade the quality of pain. More patients in the popliteal group graded it as good compared to the subgluteal. So I don't do subgluteal for my ankle and foot surgeries unless I cannot put my catheter in the popliteal sciatic area for various reasons. Then came the bigger study that gave me some insight into the whole thing. Okay, I sent them home with my home regional with an elastomeric pump, and Alain Bourgeat from Switzerland did a study, and he looked at 1001 cases, and he gave 40 mils of 0.5% ropivacaine followed by 0.3% for the first 24 hours and then 0.2% infusion. He had a 97.5% success rate. He uses only peripheral nerve stimulation. He didn't believe, up until I knew him last, he didn't believe in ultrasonography. He was dead against ultrasonography for the longest time. I get 100% success rate with my block, why should I change? But he gave me some information with regards to what are the complications that I get into with my pop side block. So the number of surgeries that he did were a wide range actually. Okay, patients in which the popliteal catheter was combined with the femoral block are marked in the asterisk. So a number of them were combined with the femoral block. So what did he notice? When he had an inversion, the success rate was much higher compared to plantar flexion when he did it for the ankle surgery. Average infusion was 48 hours. No catheters were removed for lack of efficacy. Acute complications were 1.7%, which is paresthesia on insertion of catheter. 0.5 to 0.8 acute paresthesia during the block, 0.2% catheter dislocation, no persistent paresthesia, 2 positive cultures from the catheter, no neurodeficits, no supplementary narcs required if surgery did not involve femoral territory. So he proved to me, yes, it can work. Yes, it can work for 48 hours with minimal morbidity to the patient. The infection would have really alerted my surgeon. They would have been beside, particularly if they did an ankle arthroplasty, that might be a big no from my surgeon. But my surgeon do raise objections to popliteal block because they are worried about the compartment syndrome. That is the situation I am in now, and I'm going to just give a reference with regards to that. So can I escape the catheter? He had 2% catheter failure or fallout. So this is the more recent study, 2009. So they used Perineural Dexmedetomidine added to ropivacaine, and they found that it produced dose-dependent increase in the duration of antinociception in the sciatic nerve block of the rats. So this is without the dexmedetomidine. As you keep on increasing the dexmedetomidine, the last graph is 20.6 microgram per mil. So that is 20 microgram per kilogram.
There is a humble request from the organizers that they are half an hour late in the schedule, so can you little bit...
Oh, I should stop now?
No, you can just within 1 or 2 minutes if you can.
Okay, all right. And this has been further reviewed by Peter Marhofer, who also found it prolonged it from 350 to 555 compared to systemic dexmedetomidine. And lateral popliteal sciatic nerve block was not as good as the posterior sciatic block. That is a message from that study. Ambulatory perineural infusion, again by Ilfeld, more than 97% of the patients said, I could remove my catheter myself, and they did. That was the practice at Duke University. Patients removed their own catheters, and they felt it wasn't very stressful for them. So if you think you want to provide 48 hours of analgesia, put a catheter in. There is another group that studied recently, and they had 400 continuous popliteal sciatic blocks, and they had complications galore. They went home, and the patients had so much more pain. They had a mid-thigh abscess. That's no good. So when the patient goes home with a single shot block, develops pain middle of the night, they wouldn't know where to go. They are besides themselves. To mobilize help middle of the night is tough. So there was an invited commentary from the surgeon. He said, you guys watch out, just don't stick needles into my patients if we cannot provide analgesia for the duration of pain. And other complications can happen. This patient fell down, tripped down and fell and broke her bone. So you have to keep in touch with them if you are sending them home. In conclusion, large-scale studies done with rigor document safety of continuous sciatic block. Dexmed could be an alternative until the home regionals is set up. Transitional pain has to be aggressively attended to. POPSI blocks are particularly useful as they spare the hamstrings. And that's it from me. Thank you.
Thank all the